Hi guys, welcome back to Codemaster Coach, your medical coding tutor. In today's video, we are wrapping up the UHDDS, yes, the Uniform Hospital Discharge Data Set. Now, as I started this series, I said that it applied to inpatient coding. So how do the UHDDS apply to outpatient or other settings? Well, we said in our UHDDS definition of a principal diagnosis that the principal diagnosis is that which after study. So if you were to, for example, be coding in an outpatient setting in a physician's office, you don't have that after study. Because think about it, when you go to your physician's office, you just go in with the complaint and you go home. There's no days of lab work or x-rays or whatever that can be done for the physician then to say after study. So if your physician can't identify a definitive diagnosis for your outpatient visit, then as a coder, I just assign a code for the patient's chief complaint or their signs or symptoms. What brought them into the physician's office today? For example, palpitations, rapid heartbeat. If my patient comes in with palpitations on an outpatient basis, because there's no time to do echoes and lab work and whatever, then the only diagnosis that I can code is palpitations. Whereas on an inpatient basis, it would have allowed them to do all the extra lab work, and in the end they found out the patient had atrial fibrillation. Well, then I wouldn't code the palpitations. On an inpatient basis, I'd code atrial fibrillation because after study it was found that that patient had atrial fibrillation that was causing the palpitations. So again, think about what setting you're coding in, and that will help you determine how to properly code. All right. For example, I just gave you an example for an outpatient and an inpatient. What about long-term care? As a coder in a long-term care setting, my patients are coming in because usually they're older, and because they're older, it takes longer for the disease process to heal, and they need assistance with that. So with long-term care, a fractured hip, a lot of times patients are put in long-term care facilities so that it allows them a longer time to have services to help them heal. So as a coder, I'm going to code that fractured hip. And if for any reason while they're in long-term care they have to go back into the hospital, acute care, inpatient, for something else that might have occurred, and then are brought back, again, it's whatever reason brings them back to the long-term care facility. And you have to think about that with psychiatric facilities. If you're a coder for a psych facility, whatever diagnoses justified them going into the psychiatric hospital becomes your diagnosis that you code. And it just goes on and on. Home health, rehab, nursing home, etc. Okay, so just think about the setting that you're in, and that helps you determine what you as a coder are supposed to be coding. Okay, and then procedures. With procedures, any procedure that your physician, not your nurse, not your technicians, but your physician completes as a coder, I code those procedures. Okay. I can't close this chapter that we're studying on UHDDS without talking about ethical coding. And yes, ethics comes into play with coding. You as a coder have to apply all of your instructions, your coding guidelines, your directions in your book. As you're coding and your book says, if this UTI is due to yeast, then rather than code one code for UTI and one code for yeast, if your directions in your book say UTI, yeast, use this one code, then you use one code, not the two. Not a code for UTI and then a code for yeast. In your book, it will direct you. If it's a UTI due to yeast, use this one code. If you use the two, you'd get reimbursed for the UTI, you'd get reimbursed for the yeast, which could be overcompensation versus using the one code that's going to capture them both. So that's where your ethics comes into play. So you can actually overcode in that situation. Undercoding is just as bad, because undercoding could result in financial loss for the facility that you're coding for. So you have to be very careful there as well. You might get in a situation where a family member of yours might come in to see the doctor, and you don't want to code or capture every single diagnosis. Well, the train of thought I always tell my coders is, not only are you coding that patient chart, but when it gets to the third-party payer, true, they're going to render payment based on your codes. But don't think they're not overseeing you, monitoring you. So over and under coding can be a result of loss or fraudulent activity. And there is a code of ethics for coders. And in the description box below, I have a web address to the AHEMA student, or the AHEMA Standard of Ethical Coding. And I'd like each one of you to go into that website and review the ethics of coding, because we as coders take oaths just like physicians. I've had some situations in my lifetime with coding. I've had a student, a graduate of my program, call me back and say that she was told at her outpatient facility to assign a chest x-ray to every person that was seen in their clinic. So if you come in today, an automatic chest x-ray was charged to your account, whether you received it or not. And that is fraudulent activity. That's seeking reimbursement for services that were not rendered. Also, as you're coding, you'll start to see the value of your codes. You will learn, especially on an inpatient basis, when I'm assigning codes, I can see how much each code is worth. So I know where my top dollar codes are and where my low dollar codes are. But as a coder, I have to code based on what's documented and what justifies that principal diagnoses and what other diagnoses I can assign. So again, ethics is coming into play. I have to do based on the law what I'm required to do. And so there are rules that you have to abide by. And I think that's where my nursing students always tend to have the hardest time with coding. They know what's supposed to be done. They know what's really going to take place. And a lot of times, if it's not documented, as a coder, I can't code it. If it's not documented, you know and I know that he bandaged up or he sutured up that laceration. But if he didn't document it, I can't code it. Now I can send him what we call a query. And a query is a written document that says, per your documentation, patient had a 7 centimeter laceration. But you did not tell me, there is no documentation that you sutured it, that you stitched it up. Did you or did you not stitch up that laceration? And if he did, I try to get him, don't tell me yes by phone. I want him to write it in on this form. So I have written documentation that he did suture up the laceration. Therefore, I can code it. So again, ethics comes into play. So as a coder, we do have a lot of pull when it comes to reimbursement for facilities, but I want to teach you to take that knowledge, that skill, take it with utmost importance and realize the pull, the amount of weight you have when it comes on reimbursement for your facility, because you're the coder coding those charts. Okay? All right. In the coming weeks, we're getting ready to start doing our coding, so I'm hoping you guys are able to locate books. Remember, I'm not looking for you to have the newest edition of the code book. I'm asking you to go to your libraries, go wherever you need to go to try to obtain even a used book. But I just need you to get a book that you can use so that you get a feel of how we're going to go about doing our coding. I've also got another subscriber who has found websites that she's found to be able to create her own coding program so that she can do it almost free of charge. So I'll be bringing that information to you in the upcoming weeks. Any other questions or concerns, don't forget to email me at codemastercoach@gmail.com. Again, guys, welcome aboard, and I'll see you in the next one.